I wanted to carry this topic over from Dr. Campanolo's excellent talk yesterday on neuropathic pain, where she discussed mostly the medications. To address the question earlier, it's true, quantification of pain is difficult, but there are questionnaires and there's questions that we can show our patients that we can quantify their subjective complaints. And I'll briefly go over that in this talk as well. I also learned something new. Sandy had brought up that I didn't realize I mostly work with adults and not pediatrics. So the thing I learned today was that the pediatric population don't have as much complaints of pain. So the discussion today that I will present is for adults. Okay. So briefly, I'm going to go over the historical, the pharmacological, the surgical, and rehabilitation therapies. Interesting. I'd seen this actually in the Washington, D.C. National Gallery of Art, René Descartes, and realized now that it's related to the first hypothesis of pain, where the relay mechanism was first thought of as simply, for example, man touching fire and relaying it to the brain and back. Well, we've since got more sophisticated. Melzack and Wall in 1960s showed that it was not simply a relay system. Rather, it's a gate, or gate theory, and transmission of pain is seen in the dorsal portion of the spinal cord in the substantia gelatinosum, and then multiple alterable influence since then. And then with the onset of endogenous opioids and endorphins and the receptors being elucidated since the 1970s, we became a little more sophisticated. But even up to this day, there are a lot of questions that need to be answered and studies need to be performed. Briefly, I know this was discussed yesterday. In summary, allodynia is rather the response of pain, the pain response to a stimulus that's not normally provoking pain. So a feather would cause pain in some persons, that would be more allodynia. Dysesthesia is unpleasant abnormal sensation. Hyperalgia, increased response to stimulus, which is normally painful. So if someone were to bump you, it would hurt some people, but this would be very, very painful for others. Neuralgia, pain in the distribution of nerve. Paresthesia is abnormal sensation, whether spontaneous or evoked. You'd be sitting there and pain would arise without any stimulus known. Okay. So this is the official definition of neuropathic pain. International Association for the Study of Pain define it as pain that is initiated or caused by a primary lesion or dysfunction in the nervous system. So it could be central, peripheral, or even both. Keep in mind, however, that neuropathic pain may not be an entity on its own. The persons with these disorders could have mechanical pain, could have pain rather due to bony abnormalities, muscle or ligamentous injuries. So one has to, as a professional provider, has to separate the two and then address them accordingly. So common types, peripheral. These are a number of conditions that I treat and that we see also for patients with neuropathic pain. Non-traumatic spinal cord injury for patients with inflammatory myelitis, transverse myelitis, multiple sclerosis, among others. It doesn't seem much in the general population, but this is quite a significant morbidity among those that do have it. Let's see. Okay, so the evaluation. One asks on history, what are the stimulus evoked or the spontaneous event that occurs during the time of pain? What are characteristics? They're typically burning, numbness, itching, tingling, and normal sensation that can't quite pinpoint. The intensity of the pain, and that's one of the things we could use to quantify, rating the pain, which is the visual analog scale. 0 to 10, 0 being no pain, 10 being the worst possible pain, and then they can circle, the persons who are being interviewed can circle what exactly is their pain like. And that's one simple, straightforward way that we can quantify, as well as the treatment effect. What's the quality of the pain? What's the duration? What are the alleviating and aggravating factors? And this is a significant impact on participation, the functional deficits and quality of life, and the higher morbidity with patients that have these conditions. So upon physical exam, the provider will determine the type and location of the pain. Is this truly neuropathic or is this mechanical? Sensory exams, possibilities, are there deficits in one modality, hyperalgias in others? Laboratory studies, nerve conduction, electromyography studies to identify which kind of lesion this may be to the nerve, and MRIs accordingly. Okay. Quick summary from yesterday. So the pathophysiology of neuropathic pain is elusive, but currently we have three theories, general theories, that is, increased primary afferent nociceptive firing, just so there's abnormal collection of sodium channels in damaged peripheral nerves, and there's ectopic firing from them, decreased inhibition of neuronal activity in central structures, as well as altered central processing or irritability due to deafferentation. What I'll go over in terms of the medical medication aspect is to just highlight the ones that are more emerging and the ones have not been used traditionally and are being trialed currently. In essence, when you treat a patient with neuropathic pain or pain in general, as what we say in rehab, and from the excellent talk from Dr. De La Torre yesterday, is that it's a comprehensive approach. It's a functional approach for the person who's experiencing pain and for all the specialists as well as care providers trying to see if we can manage that pain. Fortunately, we don't have direct cures. We have mostly controls of pains, pharmacological, surgical, and non-interventional. And each case should be individualized as well. So what I'm going to highlight again are those. What's also important, but would not be in this talk, is education, family, patient education, as well as psychological counseling. So it is true, it's limited randomized controlled trials. Sometimes the medications and treatment have been adopted for central and peripheral. Titrating is very important with whatever medication is chosen, and monitor the adverse side effects. As you heard yesterday, gabapentin is one of the first-line agents. The action is to decrease membrane excitability of high-frequency repetitive firing of action potentials by enhancing the sodium channel inactivation. So there are several randomized controlled trials, both in peripheral and in central. Doses initiate about 100 to 300 milligram doses. You titrate up. What's important is the common side effects during this trial that you may be, if you're a patient or a provider. Cognitive impairment is what I see quite commonly. Dizziness, imbalance. One has to look at the renal labs and the CBC as well to follow the dosing, and somnolence. Opioids. Agents that have been used for mechanical as well as neuropathic pain. And according to the current guidelines, this too falls into the first-line therapy. But one has to be careful with the geriatric population with hepatic impairment causing increased cognitive deficits, caution with overdose and drug sensitivities. One interesting thing that's being used now is the switching of opioids, thinking that perhaps if one is in brand of oxycodone can help stimulate or be adjunctive to a morphine derivative medication, so they would take both. Current Cochrane database review have not really shown this to be statistically significant, but certainly more studies need to be done. Tramadol, norepinephrine serotonin reuptake inhibitor. The major metabolite is a opioid agonist. You can titrate anywhere from 50 to 400. They usually start very low for those that I think may be sensitive to this. Adequate titration, appropriate patient without renal or hepatic impairment. Again, those labs would need to be checked on a regular basis. Adverse effects, dizziness, cognitive impairment, orthostasis, especially those that have more involvement in their nerve, more limbs that are involved, more difficulty in mobility, renal or hepatic impairment. It also reduces seizure threshold. Once again, caution with geriatric population, And it increases also the risk of serotonin syndrome. So many patients are taking a lot of medication. So when one takes another medication for pain, it has to look in terms of the whole picture. Another trend that's being used is, what about Tramadol versus opioids? Some say one is better than the other. But according to this Cochrane database systematic review for evidence-based medicine, it shows that when they compared Tramadol with placebo, Tramadol with morphine, and Tramadol with another medication, they found variable results. So essentially what this busy slide says, that there was insufficient data to draw conclusions. There's been some report that maybe there's significant effect on paresthesias, allodynia, and touch-evoked pain with certain categories of neuropathic pain and Tramadol. Yeah. Thank you. And tricyclics, amitriptyline or Elavil, nortriptyline actions on noradrenergic pathways and sodium channels, NMDA receptors, and adenosine receptors. Low dose trials is usually what's recommended, and usually that's where the pain threshold would be adequate in treating. However, what I've found in practice is that there are quite a number of adverse side effects that one approaches. One has to monitor EKG and QT interval and blood levels when appropriate, that is. There are quite a bit of interactions with other drugs that are metabolized through cytochrome P450. Again, you have to be cautious with those with autonomic neuropathy, as well as in the geriatric population. And certainly it's a contraindicator for those with arrhythmias, acute MI, glaucoma, urinary retention, and constipation, which are anticholinergic effects and will only be precipitated by this agent. This is very useful, 5% lidocaine patch, as long as there's no drug sensitivity. I find this to be very simple. It does not cause cognitive deficits, and I found that most patients do tolerate this if they feel that another medicine may cause them to go over the fence in terms of somnolence. This has been effective, at least cutting the edge of the pain. Second-line agents are currently available. Other neuropharmacological therapies you were introduced to yesterday. Other anticonvulsants or adjunctive anticonvulsants. Lamotrigine, topiramate. Interesting thing about these agents, they're new. They were studied for anticonvulsant use, but currently being thought of perhaps for pain relief. The concern, however, though, is the risk of rash and Stevens-Johnson syndrome with the first agent, and cognitive deficits like most of the other anticonvulsants with topiramate. A new agent that's just being studied among those with toxic neuropathy or diabetic neuropathy as well in animal models is Perceptide, 14-amino polypeptide. It's not currently clinically available, but it's currently in research. Heard about this yesterday as well, methadone being an MDA receptor antagonist activity and may be more effective for neuropathic pain than others. This is still, it still carries on the thought of methadone and drug addiction, and some people are not that comfortable with that. And usually what we do is use the first-line agents and then second and third line and these other alternative agents first. Ketamine, as you may remember, is a wonderful anesthetic agent, but it's also known for significant adverse side effects of dizziness, euphoria, and hallucinations. Okay. There are surgical interventions that certain centers may be comfortable with. It's usually in refractory pain. This is not the first line, and this probably would not be the second line. So once all the other non-interventional and pharmacological interventions have been thought of, this can be plausible. One would have discussed this with your providers as a patient or as other providers and consultants. Okay. It's mostly ablative surgery. Cordotomy, I've seen just very few where they cut the spinal thalamic tract, which is the pain tract, when nothing else has worked before. There's multiple other ones. What I'm going to show are specifically two that we have some randomized controlled trials and some evidence-based medicine for. Dorsal root entry zone lesions. This is where they take the nerves at the dorsal entry zone and probe lesions to it to see if they can ablate some of the discomfort. Sympathectomy duration is approximately 30% in 5 years. The complication is hyperhidrosis and orthostasis. Other ablative therapies, myelotomy, concomitant spasticity treatment, and you'll hear perhaps some of this later on in the spasticity talk later today. Mesencephalop, I have problems saying this because I don't really order this, but it's for head and neck pain and mesencephalon, where it's close to the spinal thalamic tract and periaqueductal gray. Last one that's also purported as perhaps helping with pain is the cingulotomy, the stereotactic guided radiofrequency probe lesions to both the cingulate gyri. We do have some evidence for this, although it's still controversial. Sympathetically mediated pain, or that's when the autonomic nervous system or this autonomic neuropathic pain exists. Some theories is perhaps the peripheral alpha adrenoreceptors responsiveness, and drugs targeted at different postsynaptic and presynaptic areas for the alpha-1 and alpha-2 receptors. Noradrenaline produces nociceptor sensitization indirectly, so these are all sites of possible drug targets. Specifically, there's two kinds. There's chemical and surgical. Chemical being reversible and surgical certainly not reversible. Chemical sympathectomies, they use alcohol. Alcohol or phenol injections to destroy the sympathetic chain. We used alcohol and phenol in the past for denervation for spasticity. They're using this for temporary sympathectomy to reduce the pain related to it. And it's temporary because there's regeneration of the sympathetic chain. The surgical ablation can be performed by open removal or the electrocoagulation of the sympathetic chain. Quite a difficult task, but there's minimally invasive procedures using stereotactic thermal laser interruption. It all depends where the injury is. Some you can go intrathoracic if that's where the problem may be, and can be very specific where the affected limb or the pain, the sympathetic pain occurs. Complications, as you would expect, may be significant in terms of worsening of the pain. There's always a possibility for any of that in the surgical interventions. Producing new pain syndrome, abnormal forms of sweating with compensatory hyperhidrosis or a lot of swelling, and pathological gustatory sweating. So again, there was a Cochrane systematic database review on this by Myelitis and Filart. They looked at a number of studies that are currently published, and they showed that there was limited evidence in uncontrolled studies. There was some modified techniques that may be better than others that produce comparable relief with 6% phenol and less post-sympathectomy neuralgia. But more studies are needed to identify the benefits and risks of these procedures. This is interesting. The same similar technique or radiofrequency is used in alternative places in the body. This one is mostly for mechanical. I bring this up because there was a discussion on back pain earlier, and back pain can be related to either neuropathic or mechanical. I'll spend one more moment on this than I was expecting to give, but there's no definitive answer on the mechanism of action for this, but they think there's a high energy electromagnetic field very close to the nerve that's responsible to pain. So if they were to ablate it through radiofrequency, that hopefully will reduce the pain. And the current technique that they're using is pulsed radiofrequency. Hence, one of the studies, they go into the different joints in the vertebral body that may be discomforting to the patient, that they feel that the patient had some relief due to trials before the actual radio frequency. However, this Cochrane database systematic review noted that a lot of these studies were very small samples, very short follow-up, and there was a number of deficiencies, so they were not able to say that this was something they can purport as one of the key evidence-based medicine surgical ablation techniques. Again, another kind of therapy, surgical intervention that would need to be studied more. So there's conflicting evidence on short-term effect of radiofrequency lesioning for pain and disability and chronic low back pain. And there's limited evidence for intradiscal radiofrequency thermocoagulation as may be effective for chronic discogenic low back pain. Again, there's a call for more randomized controlled trials for all of these. So if anyone's interested in pursuing this research, I'm certainly sure that we would be able to impact more on pain treatments and for our patients with this kind of pain. For the next part of the surgical treatment and the last part of it, I'm going to talk about motor cortex, deep brain, and spinal cord stimulation. Essentially, motor cortex and deep brain stimulation, as in the picture beside it, they have, it's similar to a pacemaker. They put the electrodes in the brain through craniotomy and then place the box or that chamber inside, so it would track down towards the thoracic area. It's been first demonstrated for pain. As you may have heard this for Parkinson's disease and movement disorders. They've been looking at it and shown that our Japan colleagues showed 50% efficacy rate for central pain. So the electrode is placed in the epidural space of the motor strip via craniotomy. And deep brain stimulation, they stimulate the sensory thalamus or periaqueductal gray. So the proposed mechanisms are quite a few, and it's a busy slide, but essentially there's many things that could happen, and that's what they suspect may be helping these patients. Again, this is rather research-based, and some persons are using it for pain. Mostly currently it's being used for other neurological disorders. So proposed mechanisms: inhibition, depolarization blockade, and adjustment of neural activity in the targeted area. It stimulates the release of inhibitory neurotransmitters as the pharmacologic agents we're targeting. And the deep brain stimulation resembles a functional lesioning of the target, kind of like the radiofrequency or the other surgical techniques, which raises the action potential threshold or renders inhibitory neurotransmitters less effective. So they do this through stereotactic measures, and it's implanted, and the implanted generator goes on the chest, as I was mentioning. They say that there's perhaps a high success rate with failed back syndrome and lowest with central pain. This is interesting. One of our colleagues here, surgical colleagues, is currently performing these spinal cord stimulation. Actions are alpha and beta fibers, which are the pain fibers, might inhibit pain signals. So if that were targeted, it also is purported to increase the gamma-aminobutyric acid, or GABA, serotonin, or other neurotransmitters. If they do a trial and the patient does feel relief, this temporary catheter and generator becomes more of a permanent, and it's placed in a subcutaneous pocket in their abdomen. So the catheter is inserted in the epidural space to an external stimulator. And the generator would be replaced every 3 to 5 years. Complications. Yes, there are. And they include electrode dislocation, migration, breakage, pulse generator, battery failures by the mere foreign body. Also, with any procedure, infection, CSF leak, and pain. So this is sort of a picture of where the implanted generator, here it is, and the electrode is placed in the epidural space. This is a transducer, per se, to see if this chamber is working, and it's placed in the epidural space. This is the vertebral body, this is spinal cord, the nerve root coming in, and this is where they would go into the epidural space to put the catheter in. And this is how it would look on the side view. And this is, again, where the chamber is. Busy slide. Essentially what evidence-based medicine for this is they, according to the Cochrane database review, among many other meta-analysis and other reviews, I'm using this as an example, is they took a number of the randomized controlled trials and found that it may be useful for complex regional pain syndrome, or RSD, if you're familiar with it. It's sympathetic dystrophy, And some patients may have this, and other patients with failed back syndrome is what spinal cord stimulation has been used in the studies. It's also being used for neuropathic pain, although the studies are not out there yet. So the limited evidence for these two conditions, more trials are needed. Again, some are using it anecdotally for neuropathic pain. This is not a new surgical procedure, but current trends for this to optimize pain control is that they've noticed that if they change the electrogeometry, the positioning, and anode-cathode configuration programming, they're able to get a better outcome. And they also noted more recently that overlapping the regions versus making them parallel over the painful areas may be able, plus changing the anode-cathode configuration may increase the outcome and reduce the pain longer. This can be done, the pain fibers they're targeting is alpha and beta pain fibers in the spinal nerve. Now, in the same line of thought, where you inject medication or inject an electrode through the epidural space, intraspinal or intrathecal medications have been used for a long period of time. They've been used for cancer patients for morphine pumps, used for baclofen for spasticity in patients who have stroke-related spasms or spasticity, spinal cord injuries that have spasms. Morphine has been tried and true in the past, but there are new things that are coming up in different combination of medications. Morphine or a combination of either lidocaine, bupivacaine, and clonidine are other upcoming trends. Certainly complications that have with any other foreign body and with opioids is combined in this kind of procedure, and that is respiratory depression, equipment problems, infections, CSF leak, increased pain. Yeah, I'm sorry for it's not a real good picture, but essentially what this shows is the epidural space, and right here is where the medication and the catheter would be placed. And usually it's in the lower lumbar spine. Again, once again, this is the spinal cord, the vertebral body, the nerve, and then this is the epidural space where the needle is being shown to inject the medication. Interestingly enough, there is a trend now that baclofen, as I discussed earlier, an agonist on inhibitory GABA2 receptors as an antispasticity medicine, have shown that possibly by a group in the Karolinska Hospital in Stockholm, Sweden, may be used for neuropathic pain. The baclofen pump was implanted with or without the spinal cord stimulators I discussed earlier, and found that there's a decrease in visual analog scale. The visual analog scale is one of those objective measures to quantify pain, as I mentioned earlier. Intrathecal Clonidine. This was, some patients may have been on hypertensive medicines in the past. This is an older generation antihypertensive. It's being currently utilized for those patients who can't tolerate the first medication of morphine. Intrathecal Clonidine in the pump, again, it's for patients with refractory to morphine pumps. There's different ways to dose this. Again, this verbal digital pain rating is very similar to the visual analog scale. And they found in 59% of patients success in the dose titration stage. But if you look here, the study says 42% of all patients considered. So as you can probably tell, this new medication being, rather old medication being introduced into a new way of delivering medication is still controversial. And there is risk for severe rebound hypertension if one were to abruptly stop this, or if there was a mechanical problem and it was stopped abruptly. Another new intrathecal medication that was studied more recently by a colleague of ours, Dr. Peter Statz, showed that in refractory pain used in cancer and AIDS. And why do I mention this? Because we can adopt other pain medications seen to be helpful in other conditions. Perhaps we can use it for neuropathic pain. And that medicine is iconitide. It selectively blocks the anti-voltage sensitive calcium channel blockers. Calcium channels. It was done in a multi-center trial, double-blinded, placebo-controlled, and the response to treatment was 30%, the goal was 30% or greater. They showed that a significant portion of 50% of patients receiving this medication actually responded in comparison to placebo. The adverse side effects for this is confusion, somnolence, and urinary retention, and ongoing trials. In light of the time, I'm going to breeze through this. Non-interventional modalities. These are very important modalities that have been tried and true, been used for several decades. A couple of interesting things I've noticed clinically. Just as a background, however, the theoretical mechanisms for these modalities, hot and cold packs, the transcutaneous electrical stimulation, massage, is supposed to decrease activity of nociceptors or sensory neurons. There's a limited impact of depolarizing and supposed to be sensitizing agents through increased local blood flow or inhibition of muscle spasms, production of local anesthetic effects, and increased activity of mechanoreceptors or sensory neurons. Is anyone familiar with this device? Have you found any pain relief with this? This is transcutaneous electric nerve stimulation, where they have a box, a generator that's attached to an electrode, and the electrode is attached through a form of a tape in the areas that is discomforting. The stimulation of the peripheral nerves is what is thought via the electrodes on the skin, and you can vary the intensity and the frequency of this device depending on what you have, and you work with your provider with this. Adverse effects include the transient aggravation of pain as well as allergic dermatitis. There are a few contraindications, that is those with metal implants, and pacemakers certainly would not be a candidate for this. And this is where an example of where one would put the electrodes. You can see that in eBay. You can see it in multiple areas for in your local drugstore too. But one is perhaps, I recommend that one would work with the provider first before applying this. And what is the evidence-based medicine for this? Well, there's a few. As there's a Cochrane, again, database systematic review, and I'll mention in just a moment. They've noticed, however, a trend of those who are non-responders among all the other randomized controlled trials, and they found that those that had depression, anxiety, were less likely to respond to this, as perhaps in other modalities too for pain control. Also, with older adults, we have to be careful. With any kind of treatment. However, they've been shown to improve pain control for those with chronic low back pain, which is suggested to be mechanical pain. So this is the review I was just mentioning by Gadsky et al. They looked over a number of trials and saw that although it's a low sample of 288 participants in an age group of 45 to 50, equal numbers of men and women, they did find an improvement for pain when compared to placebo, and different frequency and intensities were varied accordingly. And they showed that even though they were varied in frequency and intensity for this device, there was short-term reduction in pain, an improvement in the range of motion or the ability to move your limb in chronic pain patients. So this is promising. Another review, although inconclusive evidence, it's very promising to see that there's more literature and more research being done for these non-interventional. They don't require surgeries. There are less side effects when it comes to cognition. So it's good to see the non-interventional treatments being studied. This one specifically, another Cochrane review for chronic low back pain showed that for active controlled studies, 5 of the 7 studies, when compared to this high frequency or low frequency TENS or transcutaneous electric nerve stimulator, really couldn't find much analgesic efficacy. However, there's a difference between multiple dose treatments compared to one treatment, and they feel that multiple dose treatments are more effective than single dose treatments. So the studies were varied, hence perhaps the inconclusive evidence. But you can try it with your patients, or for patients who may be interested in having their providers look into this for their pain relief. I mentioned this because I mentioned the next two because I've seen it more in the news, and I'm sure it's on many people's minds. I'm running a couple of minutes late, but I'll run through this rather quickly. I mentioned this because I've been approached quite a number of times by patients and other providers if this has been useful. So massage increased pain threshold through release of endorphins. There's multiple kinds of massage. There actually was a review, a Cochrane database review, to see if there was any evidence regarding this. And they showed that with these patients, it was equal to corsets and exercise. It was superior to relaxation therapy, acupuncture, and self-care education for chronic low back pain, and effects lasted for at least a year. And it might be beneficial for subacute and chronic nonspecific low back pain, which I found quite interesting when I looked at this for this talk. What is this? The magnetic therapeutic products. The last part of the talk, and I promise I'll end in a minute. I found this very interesting. Again, I bring this up because this was quite a popular question to me over the past year. Magnetic therapeutic products, you put it in insoles, you put it in jewelry and multiple other areas. Do you remember the history of animal magnetism? Franz Mesmer, or mesmerized, as you may now know the terminology, was one of the first saying that there was magnets and that perhaps there was animal magnetism resided in himself and various materials like magnets that would allow the flow of universal fluid between him and his patients. Well, there was, King Louis XVI came and said, let's find out if there was any kind of validity to this. Benjamin Franklin looked at it and said, well, perhaps it's more like power of suggestion. So it waxed and waned in terms of its popularity. Even Mesmer himself, who was later coined with the term hypnotic trance because magnets were thought of more producing hypnotism that may not be useful. But now this is one of emerging treatments. They're using magnets for fractures or rather for bone healing in surgery. You don't use it as much as an MRI, which is 200,000 Gauss. And the magnets marketed for this treatment is about anywhere from 300 to 5,000 Gauss. There's certainly a lot of data that needs to be collected before this can be purported as a tried and true, but it's very interesting because it's a re-emerging modality. Currently, there has been the National Center of Complementary and Alternative Medicine and scientific investigation for claims of the paranormal said this is still in the works. It still needs to be studied more. There's a lot of things that may play a role by increasing the white blood cells, immunology, and such. And I hear the music playing. But Dr. Valbona, which is one of my previous mentors, and Baylor had looked at post-polio patients and found that this may be helpful in musculoskeletal discomfort. And this is one of the first few studies that actually showed that there was some evidence base that this may be useful. Essentially, they're still being studied. It's being studied for musculoskeletal pain and neuropathic pain. Thank you very much for letting me run over. I hope this showed you new clinical pharmacological studies and some rebirth of new medicines. So I hope you enjoy your summer. Thank you.
All right. Before we do questions, we do want to stay on time. So some people may want to take a break. So I would say if you do, go ahead, because what I think we should do is we can talk through the break. Some people will want to do it, and then we're going to start in just a few minutes with Dr. Calabrese. So for those of you who want to take a break, feel free to get up and do what you need to do. But for those who want to ask questions, go ahead. How do we get a copy of these slides?
Oh, we can get it. We can get a copy for that.
We'll make it available to you. I don't know how. On the website. Okay, good. Questions? Was that question answered? I don't know, actually. Wait 1 second. Greg, what's the answer to that question? Okay, I don't know what website. Can somebody help me here? So it's on the TMA website? This information and the... I know that. Okay, so it's on the TMA website, which is www.myelitis.org.
All of the Jim is going to get all the PowerPoint presentations. Jim will get all of the video. You go to our website, you click on Symposium workshops, you go to the program agenda. All you have to do is click on the presentation. It auto loads in Real Player. And the presentations will be up there, and the handouts will be up as PDF files.
Neat. Other questions? Sir.
What we have available.
Well, will you repeat the question, please?
Yes. The question was, are there studies studying central pain with massage, the TENS unit, and the other modalities that I have presented? Currently, what I presented to you is what we have available. So we've, like other medication, like the anticonvulsants that we took and we adopted it from other patients that had discomfort, that we were trying to see if that perhaps works for neuropathic pain. The studies are still out there, and what we presented to you today, unfortunately, is what we have currently.
Question, yes. The question is, have there been any studies done for numbness? Right, so it's kind of the opposite, right, of pain. Numbness is a failure of a sensory nerve to conduct effectively, so you don't get any response upon stimulation. Whereas pain is the exact opposite. It's a hyperexcitable response. So none of these medicines, in my experience and also in the literature, really work for that. Numbness is a failure to conduct, and these things are attempting to dampen. So no. So the only thing that I'm aware of that has been tried and is effective for numbness is 4AP, Fampridine, Fampridine. This is a potassium channel blocker, and it basically allows damaged nerves to fire a bit more effectively. So I've used this actually a good deal. A new form of 4AP is about to be approved by the FDA. It's a long-acting form made through a company called Acorda, Acorda. And my experience is that it can be very effective. In fact, some people, it can turn numbness into a hyperesthesia or an uncomfortable sensation. And in some people, that transition requires them to stop the treatment, while in others it can be effective. That's the only thing that I'm aware of. Are you aware of anything else?
No.
Question.
The question was reflexology, pain, and spasticity. I am aware that that does exist. The randomized controlled trial that we do have is not, we don't have anything with regard to that. When it comes to evidence-based medicine is what would be the practice. But I understand it is an indication for reflexology.
2 more questions if people have them. Yep. I am a big believer. Dr. Filart went through this, but I'm a big believer in massage. I think it's very effective.
The question was, can pain be generated from procedural damage, such as a surgical procedure?
It can be either, right? So you can have neuropathic pain, which is really just the residual complications of nerve injury. That is static. There's no ongoing injury. And so that occurs. But recurrence of pain is often associated with inflammation. So inflammation clearly will exacerbate pain. And so it's something that we look for, actually, that if somebody has a new onset of pain, a neuropathic pain, you think about inflammation as being contributory towards that. Yeah, I think it could. I mean, you've heard from both of the surveys that pain is a very important identifying symptom in patients, and in some patients, even at the outset, it is the most dramatic or occasionally the only symptom. So yes, I think it's a very important marker. Any other thoughts, comments?
The question was, do you see RC getting better? It's certainly a difficult kind of pain. This is a complex regional pain syndrome type 1. It depends on duration. It depends on when the lesion has been addressed in terms of pain control, and it's very difficult. I have seen some alleviation of pain with the titration medications. Some sympathetic blocks have been used to produce even more pain relief, but it's true, that's one of the refractory pain entities that the medical community is struggling with currently, yes. But yes, I have seen some improve a little bit, not cured. Congratulations. Did you have a sympathetic block?
We're going to move on. We'll have to wait on that. Rosemary, thank you very much. That was great.
Thank you very much.
I learned a lot. I hope you all did too. So Peter Calabresi is going to talk to us about what the future looks like in MS and other immunologic disorders.